All right, everybody, I'm going to give us one more minute to make sure folks are able to switch over from their Zooms to join us. Oh, 1 minute is a really long time. Right. Well, welcome everybody. Yeah. Thanks, Mark. Welcome everybody. I'm Shanta Zimmer. It's really great to have everyone here. Before we get started, I want to say thank you to Erin McKay for heroic efforts to organize this virtual week of education and innovation for the campus. I think last year you all probably remember that exactly at this time we were having these phone calls that I can't even believe we were having about whether or not we should push through with our program and have hundreds of people gather in the research buildings to do poster sessions in person. And I was, thinking maybe we should hold out and see what goes on with the pandemic a little bit more. So good decision on our part to, unfortunately, but smartly cancel the sessions last year. And this year we're in a virtual space, and next year we hope to be fully back in person for our education symposium week. As a modified way of doing it, we've combined with the medical students' capstone presentations, which I hope you will join us in watching tomorrow, and also have really gathered a large number of fantastic educational research work to look at either in the poster format or as in this afternoon session in the oral format today. And I'm extremely proud and also quite impressed that people were able to put something together in a scholarly fashion this year. I feel like I myself had much trouble going one foot in front of the other some days with the chaos that we've been living through. So I hope you'll agree with me after you hear today's presentations that some folks in our world are just more successful at doing these educational and scholarly projects than the rest of us. So with no further ado, I want to say welcome to our presenters today and congratulations for being selected from among all of the abstract submissions to give oral presentations. Our first presentation is going to be from Dr. Heather Cassidy, and the title of her abstract is Student and Faculty Perceptions of Best Practices for Ambulatory Precepting in Longitudinal Integrated Clerkships, a multi-site qualitative study. Thank you, Heather, for joining us.
All right, I am happy to be here. So as Shanta told you already, the title of our study, this is work that I completed this year with my colleagues Vishnu Kulasekaran, Anne Frank, Catherine Ard, who you'll be hearing from later today, Christina Sandquist, Sheila Jimenez, and Jennifer Adams. So longitudinal integrated clerkships are growing in popularity internationally, nationally, and locally. The CU School of Medicine has a deep history with LICs and stepwise development of more and more LIC programs over the last decade, with our bold plan to bring all of our students into LICs in 2022. The popularity of LACs is due in part to the model's demonstrated benefits in leading to improvements in patient-centeredness and empathy among medical students, as compared, you can see them here, to their colleagues in traditional block models. And we also see now, we have data showing that this patient-centeredness endures even several years after the LIC has been completed. Continuity of relationships with peer cohorts, with preceptors and patients are proposed mechanisms of learning in LICs, as is the creation of an active role for LIC learners, a role that's enabled by that very continuity. But the question arises as to whether we can count on these benefits arising spontaneously from the model itself, or whether there are specific precepting strategies that effective LIC preceptors are using to optimize the model's potential. And such precepting strategies haven't really been well characterized in the literature. So our aim, therefore, was to identify strategies of effective preceptors working in LICs to optimize learners' clinical education in an LIC. And we had a secondary hope that whatever we learned could be then distilled down into faculty development programming for our own preceptors here at the University of Colorado School of Medicine. We went about this by a multi-site qualitative study. So we invited students and faculty who participated in LICs at Denver Health and the Colorado Springs branch to participate in focus groups where they would explore the strategies of highly effective preceptors in the LICs. The students and faculty were in separate focus groups. So students were talking with other students, faculty were talking with other faculty. The student participants were fourth years who had completed LICs or were third years last spring at the very tail end of their LIC year. And then the faculty actually had pretty broad representation. We had preceptors from family medicine, internal medicine, pediatrics, psychiatry, emergency surgery, and OBGYN across the two institutions. The focus groups were recorded and then transcribed verbatim and coded in pairs in hyper research. And then we applied an inductive phenomenological analytical framework to try and understand sort of what is happening here. What does the phenomenon of precepting in LICs look like? We were able to distill our results into 6 main best practice precepting themes. So precepting cognizant of LIC learning trajectory, intercession teaching in the LIC, integration of LIC learners into healthcare teams, supporting longitudinal relationships with patients, goal setting and feedback, shared maps of longitudinal markers, and then a 7th theme really focused on opportunities for faculty development. So if we're to think about precepting, effective LIC preceptors are cognizant of the learning trajectory of LIC students, and they were adapting their teaching and expectation to the time course of the LIC, which can be 8 to 10 months long. An illustrative quote from an LIC preceptor is, for this first quarter, let's work on history gathering and exam. And then in the second quarter, we'll start doing more and more differentials. And then we'll start doing more and more detailed plans. And so I try to remember to have an even flow as the year goes on where I'm changing my expectations. Effective LIC preceptors were also making high yield of intercession teaching. And by that, I mean the time that happens in between your clinic. So you can see here an A week and a B week, family medicine on Tuesday morning. What is the preceptor doing to continue engaging the student and touching the student across the arc of the week? What we found was that they were often identifying gaps in students' medical knowledge and encouraging self-directed learning towards those gaps. They were continuing to offer feedback on notes or clinical reasoning, often by email, text, phone, or epic chart message, or they were actively engaging students in this patient's ongoing story, because as you guys all know, the story didn't stop on Tuesday. So data continues to come in even as we move on from that day. One preceptor explained a good way to harness that patient-student relationship is with follow-up phone calls. I put the ownership of following up on a lab test on my LIC students in the and again, this is outpatient precepting. And a student likewise said, I think that calling patients back about results and tests and next steps is a really good learning opportunity, and having epic message conversations with your preceptor before you call the patient. Effective preceptors were also thinking intentionally about how to integrate their students into their healthcare teams. And this came about by really promoting student empowerment and autonomy. I'm talking about empowering students on the team, empowering interprofessional teachers on the team to take an active role leading the students. So for example, having the student work with a social worker or a behavioral health worker, where they could learn not just from the preceptor, but from the rest of the people who were a part of the team. And all of this ultimately went to empower the student in their care of patients longitudinally. A student explained, I think the key fundamental thing is to give your student clinical responsibility, provide them with a range of autonomy that you're comfortable with, and be okay with maybe testing those boundaries of autonomy for yourself. Effective LIC preceptors were also really thoughtful and creative about how to support students in developing longitudinal relationships with their patient. The student says it better than I could. The more that preceptors entrust you with responsibility, the more you're going to get out of it. I had preceptors who said, let's get creative about the way that you can interact with your panel patients. Even if you can't see them in person, why don't you just give them a call? Why don't you send them a message in the chart? That way I could feel like I was an active, engaged member of their care team and contributing positively to their health. Effective LIC preceptors were also really thoughtful about how they were adapting goal setting and feedback to the longitudinal structure of the LIC. So they were still doing things that we would consider awesome clinical educator feedback principles, like giving direct, timely, relevant, and specific feedback. But the time course that they were doing that on was slightly different and kind of pulled out across the arc of the LIC to be both daily as well as monthly or quarterly. One student said, I think the best relationships in the LIC are built collaboratively. So you set a foundation of baseline expectations and we can build on it from there and we can customize things because that's the advantage of having that one-on-one relationship for a long period of time. You tailor to the specific circumstances and needs of that learning environment. Ultimately, effective LIC preceptors were also sharing a map of longitudinal markers with the students, something that they could both anchor on. One student explained, I try to have that conversation ahead of time so that we're both on the same page as we progress through it. I think that's helpful just to have the dialogue early on and plan for progression. So they don't feel like when it's September and they're not getting the plan right, they don't feel defeated. They have an understanding that that's actually not quite yet expected of them and we're progressing towards it. This, I think, leads us to this concept of opportunities for faculty development, because for a preceptor to be able to put forth a map of longitudinal markers, they have to understand the structure of the LIC, the learning trajectory of the LIC, and how intersectionality happens between different specialties that students are learning simultaneously in the LIC. So they really have to be bought into the LIC model. And students did tell us that when an LIC preceptor is not bought in, they feel it. So one student explained, instructors just continually throughout the year expressed their doubts about the foundation or the concept of the LIC. And it made a negative and weird energy to start. It's like they already didn't buy into it. So it almost seems like they're prepared for it not to work very well. But in contrast, the preceptors that really bought into the model, they were able to utilize it to teach me much more effectively. So what do we need to do then when we think about faculty development to help preceptors make that leap? I think it's important to mention out that these themes were duly identified. So we did develop the initial code book from the student data, if only because that was the first focus groups that happened, were the student focus groups. And we were really expecting that when we went back, we would have to update that code book to reflect the faculty data. It actually didn't happen that way. When we went back to the faculty data, we realized that we had already hit saturation and that faculty were giving us different examples that still correlated to the main themes and codes that we'd already identified. Really, these were all emphasizing very intentional precepting practices that were adapting core clinician educator concepts to the form and the structure of the LIC. They were also really talking about a dynamic interplay between students and preceptors and teams and patients, and that this was taken longitudinally across the arc of the year. It makes me wonder whether there are things we need to do to really teach our patients, our preceptors and our students about how to get the most out of the model, knowing that we want our patients to be a stakeholder here ultimately as well. I'd really like to finally just close and talking about this as part of a larger culture shift in medical education. Development of a new LIC site involves recruitment of new clinician educators or transition of faculty from block model into the LIC. And most of our clinician educators, they didn't train in this model. So the very precepting concepts that we're talking about here may not be intuitive to them. We're gonna have to think about how to really train them in those concepts so that we can actually leverage the model to get the most out of it. we're really thinking about how to do that as a team using this data, and have proposed developing a faculty development manual that can be a resource for our LIC directors, liaisons, and preceptors, and maybe ultimately our students as well, to help propagate these concepts about high yield, effective precepting techniques in the LIC. We had some support from the Kettering Family Foundation, and just wanted to thank our awesome investigative team, and then the LIC students and preceptors at Denver Health and the CSB, who gave us a lot of time and energy and ideas for the focus groups themselves.
Great. Thank you so much. How about some virtual applause? Great job, great job, and congratulations to your whole team. Heather, I think if one of the things that I know you all are working extremely hard on this, and I wonder if what your thoughts are on the ability of virtual versus in-person things to kind of help get people up to speed in our Zoom era. How much more value is there for in-person stuff than there is for modules or Zooms?
I am increasingly inclining to the concept that any given topic that we want to present on, so for example, if you were to look at kind of these core ideas, that having several different modalities so that you can touch different kinds of preceptors who have different time, different ability, and different needs and different ways that they like to learn is going to be where we need to head, so that we almost have a matrix where we have the topics and then we have several different potential ways to learn about them. You like to listen to podcasts? Great, we'll meet you where you are in your car. You like to be able to have dinner once a quarter on Zoom with colleagues across the state? Great, we'll meet you where you are. Your team really wants us to come in person and do something interactive and hands-on, we can do that too. So I'd like to see us thinking about a menu of teaching modalities that meets a menu of teaching concepts that we want to hammer in. I do think, though, that Zoom has broken down the barriers a little bit around just gathering in this kind of space. And I think we'll see more interest and sort of flexibility of people realizing that even if they want some stuff in person, that it's okay to participate remotely and that they can still get a high yield experience from it.
Fantastic. Great. Well, we're going to, in interest of keeping us on time, we're going to move to the next presentation. If folks have a question you want to text to me in the chat, I can try to see if we have time at the end to circle back. And in the meantime, while the slides are switching over, I'm going to introduce our next presenter, who is soon to be Dr. Mackenzie Garcia. And the title of her abstract is Development of a Public and Population Health Curriculum with Longitudinal Integrated Clerkships, a Comprehensive Needs Assessment. Thanks, Mackenzie, for joining us. And I should also note, thanks to Erin for the evaluations that are in your chat. Please take a moment to fill out evaluations of our abstracts.
All right, thanks so much, Dean Zimmer. So I am going to be talking about a needs assessment that I did along with Dr. Jennifer Adams, who's also on the call today, focused on being able to understand the needs at our institution in order to develop a public and population health curriculum for our new TREC curriculum, particularly during the longitudinal integrated clerkships. Oh. There we go. So for a little bit of background, there's been growing recognition really over the last several decades about the importance of educating MD students and DO students on public health concepts. It really isn't a new idea, but really the pandemic and the highlight that has been placed on the public health crisis around racism has really brought to light a lot of this importance in the last year. And as I'm sure many of you know, and as Dr. Cassidy alluded to, our school is going through our curriculum reform process, and our new curriculum, the TREC curriculum, will involve longitudinal integrated clerkships for all students during their second year as their foundational clinical training. And it will also involve a few different core pillars, one of which is health and society, which focuses on kind of everything around doctoring that doesn't have to do with kind of clinical science or basic science. It's all of those other factors that go into learning how to care for people in the context of their community. And so the health and society thread is longitudinal throughout the 4 years. And in that, students will be exposed to public health concepts. But really what this needs assessment focused on as I mentioned, is during that LIC year, what kind of content do we need to teach folks about public health and population health? And so in that, all students will get some foundational public health concepts through their LIC year, through some didactic content. And then some of these LICs that are groups of about 10 students at certain locations will focus specifically on public and population health as an area of concentration, whereas others will focus on things like research or quality improvement. And so really what we needed to do was do a needs assessment in order to inform the development of curriculum for that LIC portion of the trek. And specifically, what I wanted to do was create a pilot program to implement during the existing Denver Health LIC so we could get some pilot data to help us inform those future LIC curriculums. And specifically, this centered around Denver Health, but we're hoping can be used to kind of integrate into some of those other LICs at other sites. And so really this project had 3 phases: the needs assessment, which I mentioned, then I developed curriculum around this with partnership from a lot of other folks on campus. And then we've been piloting that curriculum this year and getting evaluation data. But this presentation is really just focusing on the needs assessment, mainly for the sake of time. So in order to do this needs assessment, we had a survey that we conducted with some key stakeholders who I'll get into in a minute. But basically, we wanted to get insight from them about what were the most important things in the very kind of broad field of public health for medical students to know. And this survey was pre-tested with a couple of students and also a faculty member. And what our survey consisted of was both a quantitative piece and also a qualitative piece. And so the quantitative piece focused on 12 competencies that were developed previously through a partnership of the AAMC and the CDC called the Regional Medicine and Public Health Education Centers. Those were developed over 10 years ago as kind of key competencies that that group thought would be important for medical students to have before graduation. And then we also wanted to identify other things that our kind of local stakeholders thought were important to teach, both related to those competencies to focus in more on specific content areas, and then also anything that maybe the competencies didn't address. We also wanted to identify gaps in the curriculum, and so we could tailor this to what already existed and what didn't exist, and then identify some motivation for medical students and clinicians to be involved in public health. And so this is just a slide showing abbreviated versions of those 12 competencies that I mentioned. And so they focused on understanding social determinants of health, being able to appraise and understand evidence and literature, apply prevention strategies, understand ethical implications around public health, be able to identify community resources, quality improvement, understanding the organization and financing of the healthcare system, being able to discuss the function of the public health system, explaining the importance of community engagement, being able to assess the population health of a community, being able to integrate kind of individual biologic information with population factors within the clinical setting, and then participating in population health improvement initiatives. And so this survey, we included 4 buckets of people in our needs assessment. And so we had curricular faculty in the School of Medicine who were involved in health and society or evidence-based medicine, as well as some other folks who are working on planning the LICs as future directors. We had a wide range of public health faculty who we recruited through identification of a kind of public online database of different folks across different specialties within public health, as well as some known folks that I knew through my public health training. We included students and residents with either an MPH or an interest in public health. And then because we were tailoring specifically to Denver Health, we got Denver Health clinician input and tried to target folks who had some involvement in public health. Overall, for analysis, we had Likert scale scores for each of those competencies and averaged those across all respondents and then each role-based subgroup and did ANOVA testing to compare those means. And then for the qualitative, more open-ended questions, did a kind of basic coding and content analysis, and then deductively grouped those codes into themes based on the existing competencies, and I'll get into that in a minute. So these were our participants. We had a total of 61 folks, a response rate of 50%. And this is just a list of the average score for each of the competencies. And I ordered them here by the highest score. And the higher score, closer to 5, means that people thought these were comparatively more important than the others. And I'll just highlight here, the top 3 here focused on social determinants of health, evidence and literature, and then prevention. And then I'm not going to go into all of this, but this is our comparison table across those subgroups. There were 2 statistically significant differences across subgroups across all 12 competencies, and they both consisted of differences between the students and the public health faculty. So you can see here that students felt like identifying community resources was significantly more important than public health faculty thought that it was. And then here, public health faculty thought it was significantly more important to be able to discuss the function of the public health system, probably largely because they're much more exposed to that than students are who were involved in this. So this is just a word cloud highlighting some of the codes that came out of the open-ended questions around the most important public health concepts. I'm not going to read all of these, but just wanted to highlight that really this overlaps pretty well with the quantitative data we got. So these kind of more prevalent codes around social determinants of health, literature, and prevention are pretty prominent throughout that data. And then also healthcare finance, economics, and costs came up a lot. And then policy was another one that was significant. And so in terms of themes, we grouped codes into themes, as I mentioned, by the existing competency. So if a code fell into one of those competencies, we sort of paired it with that competency. And then there were some things that really weren't covered by existing competencies, and those fell into professional humility. So recognizing when something is really in the wheelhouse of a public health professional and not a physician, interprofessionalism, and then the scope of medical care compared to public health interventions for health outcomes. And then from this, we developed curricular sessions. I'm not going to go into depth about all of these. The ones that are bolded are ones that we were able to pilot this year. But as you can see, we tried to tailor having more sessions in depth focused on the content that had higher ratings from the Likert scale scores. And then we also tailored these sessions based off of those qualitative responses as well. These go on because there's several of them across all 12 competencies. But overall, we were able to pilot things across most of the competencies, but not all of them this year. So some strengths of the project, we did include both perspectives from public health and medicine, which I think is really critical because oftentimes in medicine, we kind of work in our own silo and don't always get the perspective of experts that we need. We did tailor it specifically to Denver Health, which is both a strength and a limitation. I think it was helpful for developing content for our Denver Health LICs or LIC. And I think it can be a limitation in that it may not be as applicable to some other areas. Particularly, I think having input, there might have been limited input around rural sites as well as global communities. And then we did have coordination with the existing and planned future content. Other limitations, we had a convenient sample really through myself and Dr. Adams, and then getting additional insight from other folks we knew. And then we didn't have any community members involved in the needs assessment, which I'm a big advocate for community involvement in curriculum since they're the ultimate end user, but we will be including them in some curricular elements. And then I was the single coder for all of our qualitative information. So overall, there really has just been, as I mentioned, a huge highlight of the importance of this content for medical students. What we found is really that those competencies that were developed over 10 years ago really still held true and aligned with our local needs. And then most prioritized areas were social determinants, literature evaluation, prevention, and ethics. And ultimately, it's important to have folks from multiple levels of training and across both disciplines to be involved in this work moving forward. Huge thank you to Dr. Adams and then many other folks from the School of Public Health and all those who participated in this, including, I'm sure, some of you on this call, and I appreciate all of your insight.
Great, thank you so much, Mackenzie. Another round of virtual applause. Congratulations to you and also your co-authors on this abstract. While I, agree with you in terms of the importance of this particular content area, you also gave us a really nice lesson in curriculum design with that presentation. And I wonder if you could give one piece of advice to folks who are picking other themes within their LICs of kind of where to start, or whether or not this type of qualitative project is the way to go, whether you're doing something related to equity or you're doing something related to inquiry and science, for example.
Yeah, so I think this was really valuable in that we had a little bit of luxury in terms of having, I was working in my public health year of training when a lot of this kind of data collection was going on. And so I think that's a luxury that perhaps not everyone has is that resource of having someone who has kind of additional time. Along those lines, I would suggest involving students in this process because sometimes students are looking for projects, maybe do have expertise in some of these areas, and may have more time than you all. And so really being involved with students to kind of be able to approach things from this broader needs assessment might be a really valuable thing for people to do.
Fantastic. Student involvement for the win. If there are other questions, please type them to me privately. In the meantime, we'll switch to our next presenter, former student and now Dr. Catherine Ard, and her abstract is entitled Professional Identity Development Within Longitudinal Integrated Clerkships, a Qualitative Multi-Site International Study. Thanks for being with us, Catherine.
Thanks, Dr. Zimmer, and thanks to all of you guys for being here. I really appreciate you guys taking the time. Let me just get my screen shared here and then we'll dig into it. Perfect. So I am excited to have a few minutes to talk to you all today about professional identity development and what that looks like in longitudinal integrated clerkships. No disclosures. I wanted to start with talking about this concept of professional identity formation. In 2010, the Carnegie Foundation published this idea that the process of professional identity formation is really more than the acquisition of knowledge and skills during medical school, but it also includes the deepening of one's commitment to oops, sorry guys. Am I still sharing my slides?
No.
What happened? Let me go back into sharing here.
I'm glad I'm not the only one who does that.
Let's share.
There we go.
All right. Getting back into it. So I was saying it's this process of deepening one's commitment to the values and disposition of the profession into the habits of the mind and the heart. And they really called for professional identity formation to become a centerpiece of medical education going forward. They recommended things like really focusing on reflection, developing strong relationships between faculty and students. And that's what brings us to this concept of LICs, which have been discussed previously, so I won't go into. Previous data has shown that LIC graduates are more likely to practice in underserved areas of medicine, including a study done here at the Denver Health LIC, where they coined this term, the health equity professional identity, after they showed that graduates of their program were more likely to practice patient-centered care and also more likely to advocate for underserved patients going forward in their career. One limitation of this study was that it really only focused on the LIC here. And so the question remained, was this just something that was going on at Denver Health, or could we say that this professional identity development was consistent across LICs all around the world? And so that is how our research question was born. We wanted to ask, does participation in an LIC affect professional identity development? And if so, how? To try to answer that question, we really wanted to talk to students in LICs and ask them a lot of questions. We wanted to know, when have you felt like a doctor? What have your experiences with your cohort patients been? What's important to you as you go forward in your career? What's been your experience with the hidden curriculum and how has that affected you? And tell me about your role models in medicine and what they have done for you. So we designed a study that was qualitative, longitudinal, multi-site, and international. We recruited 33 LIC students from 4 different LIC sites, including here at Denver Health, as well as 2 sites in the UK, Hull, York, and Dundee Medical Schools, and a site in Ireland at the Limerick School of Medicine. We collected a lot of data, including extensive entrance and exit interviews from everyone, as well as audio diaries that were recorded throughout their LIC experiences. And during these interviews and audio diaries, students were really responding to prompts about the questions that I had on the previous slide, as well as many other topics related to professional identity development. And then we analyzed these results with multiple researchers coding each transcript using an inductive iterative process. I do just want to highlight the advantage of having these multiple sites gave us. So we were able to analyze LICs from lots of different perspectives and lots of different settings. So the Denver Health LIC has 10 students annually, and those students are placed in an urban safety net setting. These students do have to apply and be selected to participate in the LIC. If you compare that to the Limerick LIC, where all 150 of their students participate in an 18-week-long primary care rotation that counts as an LIC, and they're dispersed across 140 sites there. The whole York LIC was studied in its pilot year, and their 6 students were mostly in a primary care setting for the full clinical year. And then finally, the Dundee School of Medicine has 10 students that are placed in largely rural placements. So we were really able to study all of these different sites at one time to give us insight into how do these different settings, how do these different curriculums contribute to the professional identity development of the students in these different LICs. Results that we have thus far include 5 major themes and their associated sub-themes. So major themes have included the authentic role in patient care, the importance of longitudinal relationships coming out of these LICs, a strong sense of moral identity, and the effect of the LIC on different career aspirations, as well as a sense of resilience. And I do want to point out that this theme of resilience seemed to be much more prevalent in the Denver Health data than compared to the other sites from overseas, which we'll get into in a little bit. Digging into the data specifically coming out of Denver Health, we're really seeing how strongly these major themes affect our students as they're going through their training. So when speaking about an authentic role in patient care, this student said, "The LIC has helped me transition from seeing myself as a medical student to seeing myself as a physician. I think in the LIC, we have more of an opportunity to take on more responsibility in patient visits, and that makes me feel like a grown-up doctor." When talking about longitudinal relationships, the student said, "My favorite part of the LIC was that I just had these mentors throughout the whole year, and they were the ones who guided me and knew me all along the way." In talking about moral identity, the student said that the LIC reinforced that this is the population I want to work with, and that I'm still very much interested in working with communities regarding health equity and social justice, and that there are concrete ways to battle all of those injustices. The LIC affected students' career aspirations in different ways. This student spoke specifically that it reinforced that they should probably go into primary care because they really like those long-term relationships, and that while they really like both inpatient and outpatient medicine, they really enjoyed that relationship building and wanted to get to know someone over the course of time. And then finally, the piece of resilience, which, as I said, was more prevalent at Denver Health. Students here tended to talk more about secondary emotional trauma and burnout than students in other settings did. But they also talk about what they learned and grew from that. And the student said, for example, it was sometimes easy to feel like not a good LIC student if I didn't do something extra special for each patient, but I came to realize that's not a reasonable expectation. And so I started to try and be compassionate toward myself. So looking at all of these themes and sub-themes, specifically in the Denver Health data, we start to see emerging a conceptual framework of inputs and outputs as they relate to professional identity development. The inputs are the things that directly affect the medical students, things like these mentors, the authentic team role, patient relationships, and the environment in which they're placed. And these inputs we see really help to develop young doctors with a strong professional identity who are then able to produce different outputs and give back to the medical community. And so these outputs, again, represent the students and the young professionals' professional identity. They include things like their patient-centered approach to care, their sense of belonging, their resiliency, and their mission and purpose that they take with them as they go forward in their career. And I do want to say that, this framework does seem to hold true with the Denver Health participants and is consistent with data from prior studies. But we're still really teasing out the details of what this looks like in other LICs and what can be applied as a single unifying framework and which parts are unique to different LICs and settings going forward. Finally, I want to discuss next steps and applications with this data. So as I've said, we're still doing ongoing analysis across sites. We did collect a ton of data here. One of our co-authors, Megan Brown, who is out of Hull, York in the UK, is actually doing her PhD thesis with this data. So you can imagine we've really just skimmed the surface here. But one thing that I think we're all really excited about is to look at these nuances that are coming out of the different curriculums and really trying to settle down on what is the single unifying framework of professional identity development in LICs and what are things that are unique depending on the setting or the curricular aims and other differences in the LICs. I'm especially excited about this as we talk about curriculum reform here, as we're moving to a medical school that is all LIC. I think we need to think intentionally about how the different settings and different curriculums of these LICs are going to affect our medical students going forward. And then there were a couple of unexpected, but I think really interesting outcomes that we're getting from this study. The first one is that we're really seeing how big of an effect the healthcare system itself has on students. And when we look at the data coming out of Colorado, we see students talking a lot about the broken healthcare system and the stress and the worry they have about finding adequate care for their patients. And if we contrast that to students, on the other side of the pond, they're really not talking about this at all. And we're assuming because of that, that they're having less secondary trauma and less burnout throughout their training. And then the other unexpected analysis that we have is that the end of our data collection period coincided with the beginning of the COVID-19 pandemic, when many students here and abroad were kicked out of their clinical placements. And so many students talked about how that had an effect on their professional identity. So we're excited to go back and do some additional analysis there. So keep an eye out for additional publications and work coming out of this data collected here. I think that's all I have. I do want to say thank you to all of my co-authors and Paul, Andrew, Gabby, and Maggie, who did a lot of data collection and analysis for us as well. And that's it.
Great. Congratulations, Catherine, and thank you to you and your co-authors for that excellent talk. Lots of food for thought there. I think I need to sit down with you about some advice for some things for our curriculum coming up. But I wanted to ask you a little bit to reflect, to stretch this across the continuum of medical education into GME. What did you learn from your study that you think is relevant for those of us who are thinking about professional identity formation as it extends into the GME space? Are there things that we could apply from what you discovered?
Yeah, definitely. I think that's a great question. So I think these inputs, when we're looking at things like relationship with mentors, is one piece that's especially important in GME, and one thing that we can really capitalize on as we kind of move forward into the GME space. I think it's a little bit harder in residency to get that continuity with patients, and trying to think about ways to be intentional there so that we can, continue and build off of the professional identity that hopefully all of our residents are coming in with going forward.
Obviously, you like me chose a residency training program that had lots of different health systems or several health systems within it, citing that potentially as an advantage. But I'm worried or interested to find out if whether or not your data might start to show that residents like students should try to be in a single health system.
Yeah, I think that, the way I envision it is that there's a time to be in a single health system, and there's a time to experience different health systems as well going forward. And, I think that while we're thinking about medical students that are really kind of fragile, for lack of a better word, in terms of building up their professional identity, they really need to be kind of isolated and protected in these individual health systems. And then hopefully, as we've built up a robust sense of professional identity, kind of letting them loose onto different health systems so that they can really explore what that identity looks like in different settings with different patient populations and faculty going forward as well, is interesting.
Great, thank you.
Thank you.
As we transition to Madeline's slides, let me give a reminder that after this session, there will be a number of poster sessions, and you should have links in your emails to join those sessions independently. As you can see, we have a lot of great abstracts, so please take some time this afternoon to join for some of those other ones. In the meantime, I want to say congratulations and thank you to our final speaker, Madeline Huey, soon to be Dr. Huey. Her title is Community Partners' Experience Collaborating with Medical Students via Longitudinal Service Learning, a Qualitative Exploratory Study. Thanks, Matt.
Thanks, Dean Zimmer. Let me share my slides. So as Dr. Zimmer said, my name is Madeline Huey, and I'll be sharing my work with you today on community partners' experiences in service learning. This work would not have been possible without my co-investigators, Drs. Ty Lockspizer, Vanessa Munoz, Chad Stickrath, and Heather Cassidy. So what is service learning? Service learning is defined as service to the community in ways that are responsive to community identified concerns and is supported by pedagogical frameworks. Community engaged medical education thinks of the community as relational, not just locational, with the community playing an active role in both the learning and curricular design. And because of these things, service learning is a distinct activity from community service. The stakeholders in service learning at an academic medical institution might include somebody like the School of Medicine, the community, the individual community members, the medical students, and finally the teacher, who can be thought of as either the School of Medicine faculty who is leading the service learning course, or the community partner who the medical student is paired with. Much of the literature on service learning and medical education is focused from the School of Medicine on program description and evaluation, and also on the medical students, with positive outcomes that have shown improvement in medical students in a nuanced view of physician leadership, in higher levels of civism, and a sustained commitment to underserved populations. There's some literature exploring community partner perspectives, but these are typically included in the outcomes-based program evaluation. And while informative, the generalizability of these findings are limited. An understanding of these community partner perspectives with partnering with medical students is essential to the success of service learning courses, but it is currently lacking. So with that in mind, we developed a qualitative exploratory study evaluating the community partners' perspectives and experiences while engaging in service learning with medical students. And to do this, we conducted semi-structured interviews with community partners who had participated in longitudinal service learning with students in the Colorado Springs branch. These interviews were audio recorded and transcribed verbatim. And then we then conducted an iterative qualitative analysis using a grounded theory methodology. It's important to remember that throughout the rest of my talk, the findings are from the community partners' perspectives. And so I'll continue to remind you with this image on the rest of my slides. And I'll be happy to talk about my methodology if there are questions at the end. Our community partners represented a diverse group of organizations, including public schools, safety net clinics, direct care providers, advocacy organizations, and city recreation programs, and their logos are listed here. 4 broad themes emerged from our interviews, including the community partners' motivations for participating in service learning, their experiences while participating in service learning, outcomes as perceived by the community partners during service learning, and community partner aspirations for future engagement. Community partners were motivated to engage in service learning with the hope of influencing the trajectory of future doctors. They hope to accomplish this through influencing the professional development of the medical students, by inspiring the students to choose particular specialties, by inspiring students to set down roots in the Colorado Springs community, or by inspiring medical students to commit themselves to the care of vulnerable patient populations. And lastly, they hope to influence medical students' further development of service-oriented mindsets and habits. Community partner experiences are best defined as bidirectional. Partners viewed themselves as mentors and educators to medical students. And when we asked specifically about burdens that community partners experienced, they said that the only burden was one in ensuring that the medical students had a good experience. One community partner said it this way, making it a win-win situation as a good learning experience and also as a benefit to whatever facility or community-based organization they might be working at. Additionally, community partners identified that medical students helped fill the gap in their volunteer base, bringing a new, young perspective to their organizations. Cited challenges included high turnover of medical students, inflexible schedules as this occurred during third-year clerkships, and variable level of interest from medical students. But overall, partners expressed a need for clear defined roles and expectations for themselves and also for more structure. Outcomes of service learning partnership were stakeholder dependent. Community partners reported that for their organizations, benefits included that the medical students were able to support and come up with solutions to long-standing organizational problems. Another significant benefit was one of recognition by the School of Medicine. This was seen by the community as a reflection of the value of the work that the organization was doing. Partners also reported the additional partnerships were formed as a result of the service learning. From the community partner perspective, their clients had a change in their own perspective as they saw that their clients were able to develop increased trust in the healthcare system. And from the community partner perspective, the medical students gained important knowledge of community resources. They developed skills in communication, teamwork, and problem solving. And they also finished their service learning experiences with better and improved cultural competency. Overall, community partners aspired to cultivate physician leaders who are engaged in their communities and are using their positions to do good. For example, they want physicians to be health advocates, using their voices to inspire and improve the health of the communities they serve. The community partners also aspired for expanded roles in the assessment and evaluation of the medical students who they were partnering with. One community partner summarized our conclusions this way. At the end of the day, we always have to keep reminding ourselves that it's a living, breathing animal that we're trying to cultivate here. It changes from year to year. It's a group of people working with a group of people working with a group of people. And all 3 of those are going to overlap, but they're going to overlap in different ways. So with that in mind, we envision service learning as a socio-ecological model with dynamic, ever-changing parts. The decision-making, actions, and inactions of each stakeholder impacts the others, the way gears in a cog are dependent on one another. Importantly, community partners view themselves as part of this system with an ability and a desire to influence the outcomes. So given the socio-ecological model of service learning, it's important to understand, we know it's important to understand our community partners in order to design service learning courses that meet the needs, goals, and expectations of our communities. So some concrete lessons that we've learned throughout this process are when we design these courses, we need to make sure that we're clearly defining roles and responsibilities of all of our stakeholders, including our community members, that we improve our matching between medical students and community partners, and that we create multi-level, multi-generational curriculum that honors and supports longitudinal and sustained engagement, while also remembering that community partner voices should be involved in all of the decision making, from the development to the evaluation of these service learning courses. So with that, I'd like to just acknowledge all of the people who helped make this possible. Again, my co-investigators, the community partners of the Colorado Springs branch, the community members who are part of those organizations, the medical students, and Ben Harnicke at the Strauss Health Sciences Library. That's all I have for you today.
Thank you so much, Madeline. I'm going to give you my virtual applause as well. And one of the questions that I had about your work is really related to when the best time is to instill in students this idea that community partnerships, or that leadership is this relationship between communities and students, and sort of how do we get this? We in medicine are criticized for having this kind of hierarchical system. So how do we, when do we, and how do we get this idea that leadership and community engagement is a lateral, or maybe it's a they lead us kind of model? What are your thoughts about that, about when and how?
I think that the sooner medical students can start being exposed to this lateral relationship, the better. I know from just reflecting on my own experience and having lots of different touch points with this concept, it has taken me a long time to have that become something that I understood. And so the more and the sooner and the longer that a medical student can become engaged in these types of relationships, the more likely it is that they'll understand the true meaning of what that looks like when it's this bi-directional relationship.
Great. An important reminder for all of us. I really appreciate your talk and this discussion. Congratulations again to you and to your co-presenters. I also want to spend one moment saying thank you to the mentors out there. I hope you are feeling like I am, those mama gallina fluffy feathers on your chest as you watch our students and your colleagues and residents presenting today. It's really fantastic, and everybody stayed right on time, which is also remarkable and has calmed Erin's heart rate down quite a bit. So thanks to all the faculty, supporters, the mentors, and for our presenters one more time. A round of applause for everyone. Please take a moment to fill out the evaluations. If you have questions, reach out to these presenters individually, and hopefully some of you will also, or most of you will move on to join us in the poster presentations. Erin, thanks for putting the link back into the chat. Later this week, we have another series of oral presentations on Thursday. There will be an excellent grand rounds on Friday. There's more poster sessions to come. So thanks everybody for participating. I look forward to seeing you in the days and hours ahead. Bye.
Thank you all. For those of you who are wondering how to get to the poster presentations, please navigate to our website. Go scroll down to the presentation link or the presentation section, and then you'll click on the tab for today's date, and then you'll be able to access the abstracts, the posters, and then also the Zoom link. And the poster presenters will be within the Zoom link from 2 to 3 today. So thank you so much for being here.